skin infections because of the excoriation, and the patient is not able to sleep in the night because of the involuntary loss of urine. So here we will discuss the control of micturition. So it is basically the pudendal nerve which carries the somatic sensations from the urinary bladder and the pelvic floor muscles and the external sphincter, and it goes into the spinal cord. And then there is also the parasympathetic unopposed impulse which results in detrusor contraction. This is the motor supply of the bladder. And there is also the T10 L1 L2 hypogastric nerve which is supplying the bladder, and this has got a sympathetic inhibitory detrusor contraction during the filling phase, and it contracts the muscles in the urethra and the bladder neck. So this hypogastric nerve which is arising from T10 L2 is the main nerve which is responsible for the voluntary control of micturition, and it keeps the patient from voiding by contracting the urethra and also by inhibiting the detrusor contractions during the filling phase. Now this hypogastric nerve has got T10 L1 and L2, and when this is injured, this hypogastric nerve is injured, or any injury to these segments of the spinal cord can lead to involuntary urination. Now in the cerebral cortex, there is an interpretation of messages of full or emptying the bladder, and then there is a pontine micturition center which switches the button between the filling, storage and the voiding. This is how the voluntary control of micturition is held in place. And there is also a sacral micturition center by S2, S3, S4 which is mediated via the pudendal nerve. The pudendal nerve is mainly responsible for initiating the act of voiding. Now the master control lies in the cerebral cortex which inhibits voiding until it chooses and it is socially acceptable to void, and this coordinates the micturition reflex, and the micturition reflex is inhibited by the cerebral cortex. At the level of the spinal cord, there is a storage and filling, and there is voiding and micturition. So storage and filling is sympathetic controlled, and beta 3 plus receptors, detrusor and parasympathetic muscarinic cholinergic fibers, and alpha will stimulate the internal sphincter. And so if the internal sphincter of the urethra is stimulated by the alpha receptors, and the detrusor and the muscarinic cholinergic activity is suppressed by the beta receptors, the bladder keeps on filling and there is no impulse to void. However, if the sympathetic mechanism is inhibited by the parasympathetic or muscarinic and cholinergic stimulation of the detrusors, which leads detrusor muscle to contract, or alpha inhibition relaxing the internal sphincter, then there is the start of micturition. So this is the sympathetic and the parasympathetic control. So sympathetic is responsible for filling the bladder and parasympathetic is responsible for the voiding of the bladder. Now, sometimes there can be bladder hyper or hypoactivity, and sometimes there can also be outlet obstruction or insufficiency. So, there is a sympathetic, parasympathetic, autonomic control. There is also a pontine check switch. There is also a cerebral control, and there is also the problems of the bladder hypersensitivity or hyposensitivity, and there are also the problems of the outlet. So how do we start the workup? You should keep asking whether it is urge incontinence or whether it is stress incontinence or it is mixed incontinence. And since the patient are frequently embarrassed to discuss about this problem, you have to ask a very directed question. Do you suffer from this problem? Okay. So only if we ask, then the patients will come up with an answer. So in the history, we have to ask the patient the history of voiding, storage, bowels, comorbidities, psychosocial, developmental attitudes, values and behaviors. In the examination, we have to do general examination, abdominal examination, examine the external genitalia and check the spine, check the reflexes and the blood pressure of the patient. The basic investigations include the urine analysis, frequency of voiding, volume of voiding charts and the defecation charts. Intermediate investigations include ultrasound for the kidney, ureter, bladder, the uroflowmetry studies and the renal tract ultrasound. Other investigations include the micturition, cystourethropy, urodynamics, and the MRI spine. Now, what should we ask? So, we have to find out the etiology of urinary incontinence. So, the questions to the patient should be directed accordingly. So, how do we classify the incontinence? It can be urge. That means she feels the urge to void, but before she reaches the washroom, she has already voided. So, this is called as urge incontinence. Stress incontinence is whenever there is a rise in intra-abdominal pressure by giggling, sneezing or coughing or lifting heavy weight, then there is incontinence. Overflow incontinence is the bladder gets filled beyond its holding capacity and it overflows involuntarily. Mixed incontinence is can be a mixture of any of these, and then it could be functional or a psychosomatic problem. Now, what is the most commonest type? It is urge incontinence. Now, what is urge incontinence? It is overactive bladder. So, when we say the patient complaint is urge incontinence, the diagnosis is overactive bladder, the pathophysiology is detrusor overactivity, and the treatment is giving antimuscarinic agents. So, the cause of urge incontinence can be idiopathic, we don't know the cause, or it can be a upper motor neuron problem like lack of CNS inhibitions and stroke, cervical stenosis, multiple sclerosis. It could be age-related problems of urge incontinence. It could be bladder irritation with the presence of stones, kidney stones or bladder stones, or it could be a bladder carcinoma, or it could be a infection.